Welcome to Pediatric Case Review, Clinical Metabolic Education Series. Today we are covering Glutaric Acidemia Type 1, a comprehensive case-based review designed for general pediatricians. This is an autosomal recessive organic acidemia that can cause devastating neurological injury if not recognized early. We will walk through 15 clinical cases covering acute and insidious presentations, physical findings, pathophysiology, biochemical markers, neuroimaging, newborn screening, confirmatory testing, dietary management, emergency protocols, prognosis, and special situations. Let us begin. Case 1. A 10-month-old infant presents with a 2-day history of mild upper respiratory infection and low-grade fever. He now develops new-onset focal seizures and developmental regression. On examination, there is axial hypotonia, appendicular hypertonia, and poor head control. His head circumference is above the 95th percentile. What is the most likely diagnosis? Option A, Glutaric Acidemia Type 1. Option B, simple febrile seizure. Option C, bacterial meningitis. Option D, infantile spasms. The correct answer is option A, Glutaric Acidemia Type 1, presenting as an acute encephalopathic crisis triggered by febrile illness. During catabolic stress, febrile illness triggers massive breakdown of lysine and tryptophan. Toxic metabolites, specifically glutaric acid and 3-hydroxyglutaric acid, accumulate acutely in the striatum. This causes bilateral striatal injury, leading to acute dystonia, hypotonia, and encephalopathy. The peak vulnerability window is between 3 and 36 months of age. Remember this clinical pearl: any febrile illness in an infant with macrocephaly warrants urgent metabolic evaluation. Case 2. A 6-month-old male infant is referred for gradual motor delay and progressively increasing head circumference noted since birth. There is no acute illness and no seizures reported. His parents note he is not reaching milestones. On examination, head circumference is above the 97th percentile, with axial hypotonia, reduced anti-gravity movements, and a fontanelle that is full but not bulging. What is the most likely diagnosis? Option A, hydrocephalus. Option B, Sotos syndrome. Option C, Glutaric Acidemia Type 1. Option D, Canavan disease. The correct answer is option C, Glutaric Acidemia Type 1 with the insidious onset phenotype. This presentation features gradual motor delay and progressive macrocephaly above the 97th percentile without an acute crisis. It is caused by gluteryl coenzyme A dehydrogenase deficiency, leading to accumulation of glutaric acid and 3-hydroxyglutaric acid. The hallmark magnetic resonance imaging finding is frontotemporal hypoplasia, known as the bat wing sign, present before neurological symptoms appear. Newborn screening detects elevated gluteryl carnitine on tandem mass spectrometry. Hydrocephalus presents with increased intracranial pressure signs. Sotos syndrome involves overgrowth without organic aciduria. Canavan disease shows elevated N-acetyl-aspartyl-aspartate in urine with diffuse white matter involvement. Case 3. A 4-month-old infant is brought for a well-child visit. Parents report no specific concerns. On routine examination, head circumference plots above the 95th percentile, while weight and length are at the 50th percentile. The anterior fontanelle is open and not bulging. Neurological exam is otherwise unremarkable at this visit. Which physical finding is present in approximately 75% of Glutaric Acidemia Type 1 patients at birth or shortly after? Option A, microcephaly. Option B, hypotonia. Option C, spasticity. Option D, macrocephaly. The correct answer is option D, macrocephaly, defined as head circumference above the 95th percentile. Macrocephaly is present in approximately 75% of Glutaric Acidemia Type 1 patients and is often the earliest detectable sign. It can be present at birth or develop within the first months of life. The macrocephaly is progressive and typically tracks above the 97th percentile. Importantly, it reflects frontotemporal hypoplasia with expanded cerebrospinal fluid spaces, not hydrocephalus. This finding should trigger immediate metabolic workup, including urine organic acids and plasma acylcarnitine profile. Case 4. A 2-year-old boy with known Glutaric Acidemia Type 1, diagnosed via newborn screening. presents after recovering from an acute encephalopathic crisis triggered by a febrile illness. He now shows persistent abnormal posturing of his limbs, involuntary twisting movements, and difficulty with voluntary motor tasks. What is the most common long-term movement disorder following an acute Glutaric Acidemia Type 1 encephalopathic crisis? Option A, dystonia. Option B, hemiplegia. Option C, ataxia. Option D, Parkinsonism. The correct answer is option A, dystonia secondary to acute bilateral striatal injury. During an acute febrile illness, the metabolic crisis causes glutaric acid and 3-hydroxyglutaric acid to accumulate in the striatum. This produces excitotoxic injury to the bilateral caudate and putamen. The result is irreversible dystonia in untreated children. Dystonia appears after the encephalopathic crisis, and chorioathetosis and orofacial dyskinesia may also follow. Hemiplegia involves focal corticospinal tract injury, not the bilateral diffuse striatal pattern seen here. Cerebellar ataxia implies cerebellar, not basal ganglia injury. Parkinsonism reflects dopaminergic substantia nigra degeneration, which is a different pathway. Case 5. A 9-month-old male is referred after newborn screening flagged in elevated gluteral carnitine level. He is currently asymptomatic with normal development and no acute illness. His parents are consanguineous. Urine organic acid analysis confirms markedly elevated glutaric acid and 3-hydroxyglutaric acid. Glutaric acidemia type 1 is caused by a deficiency in which mitochondrial enzyme? Option A, phenylalanine hydroxylase. Option B, glucose 6-phosphate dehydrogenase. Option C, gluteryl coenzyme A dehydrogenase. Option D, branched-chain alpha-keto acid dehydrogenase. The correct answer is option C, gluteryl coenzyme A dehydrogenase. This enzyme catalyzes the oxidative decarboxylation of gluteryl coenzyme A to crotonil coenzyme A. Deficiency causes a metabolic block in lysine and tryptophan catabolism, leading to accumulation of glutaric acid and 3-hydroxyglutaric acid, which are neurotoxic. The striatum is most vulnerable due to its high density of glutamatergic neurons. Gluteryl carnitine also accumulates, and this is the newborn screening marker for glutaric acidemia type 1. The condition is autosomal recessive, caused by mutations in the gluteryl coenzyme, a dehydrogenase gene on chromosome 19p13.2. Case 6. Which accumulated metabolite is primarily responsible for striatal damage in glutaric acidemia type 1? Consider the metabolic pathway of lysine and tryptophan catabolism. Option A, phenylalanine. Option B, ammonia. Option C, lactate. Option D, 3-hydroxyglutaric acid. The correct answer is option D, 3-hydroxyglutaric acid. This is the primary neurotoxic metabolite in glutaric acidemia type 1. It activates N-methyl-D-aspartate receptors, causing excitotoxic neuronal death. It also disrupts mitochondrial energy metabolism and generates reactive oxygen species, leading to oxidative stress. The striatum is most vulnerable because it is rich in glutamate receptors. 3-hydroxyglutaric acid crosses the blood-brain barrier more efficiently than glutaric acid, making it the key driver of striatal injury. While glutaric acid also contributes to toxicity, 3-hydroxyglutaric acid is more potent. The damage to the caudate and putamen is irreversible if not prevented early. Case 7. A 3-day-old newborn is flagged on routine state newborn screening. The infant appears healthy with no dysmorphic features and a normal neurological exam. The metabolic team is notified for follow-up. Which analyte, measured by tandem mass spectrometry on a dried blood spot, is the primary screening marker for glutaric acidemia type 1? Option A, gluteryl carnitine. Option B, leucine. Option C, tyrosine. Option D, citrulline. The correct answer is option A, gluteryl carnitine, also known as C5DC. Newborn screening for glutaric acidemia type 1 measures gluteryl carnitine in dried blood spots via tandem mass spectrometry. The process begins with a heel prick at 24 to 48 hours of life. The dried blood spot is collected on a Guthrie card. Tandem mass spectrometry then measures the acylcarnitine profile. A gluteryl carnitine level above 0.4 micromoles per liter is considered elevated and triggers immediate confirmatory workup. However, be aware of the low excretor phenotype. Some patients have only mildly elevated or even normal gluteral carnitine. Urine organic acids remain essential for confirmation. Case 8. A 6-day-old newborn is flagged on routine newborn screening with an elevated gluteral carnitine level of 0.72 micromoles per liter, where normal is less than 0.40 micromoles per liter. The infant appears clinically well, feeding normally, with no dysmorphic features. Head circumference is at the 80th percentile. The metabolic team is notified and confirmatory testing is ordered. Following a positive newborn screen for Glutaric Acidemia Type 1, which test provides the most definitive biochemical confirmation. Option A, karyotype analysis. Option B, urine organic acid analysis. Option C, sweat chloride test. Option D, muscle biopsy. The correct answer is option B, urine organic acid analysis. This is the gold standard confirmatory test for Glutaric Acidemia Type 1. It reveals markedly elevated glutaric acid, typically above 850 micromoles per millimole creatinine, and elevated 3-hydroxyglutaric acid above 100 micromoles per millimole creatinine. A critically important point is that a normal newborn screening gluteral carnitine does not exclude Glutaric Acidemia Type 1 because low excretors may have borderline results. The diagnostic pathway goes from elevated newborn screening gluteral carnitine to urine organic acids plus plasma acylcarnitines for biochemical confirmation, and finally gluteral coenzyme dehydrogenase gene sequencing for genetic diagnosis. Case 9. A 9-month-old boy presents with progressive macrocephaly with head circumference above the 98th percentile and mild motor delay. He has no history of acute encephalopathic crisis. His newborn screening was flagged for elevated gluteral carnitine. Brain magnetic resonance imaging is performed and reveals a striking bilaterally symmetric abnormality of the cerebral cortex surface. What characteristic magnetic resonance imaging finding is described as the bat wing sign in Glutaric Acidemia Type 1? Option A, cerebellar atrophy. Option B, ventriculomegaly. Option C, widened sylvian fissures with frontotemporal hypoplasia. Option D, corpus callosum agenesis. The correct answer is option C, widened sylvian fissures with frontotemporal hypoplasia, known as the bat wing configuration. This finding is present in more than 90% of Glutaric Acidemia Type 1 patients. The frontotemporal hypoplasia represents underdevelopment, not true atrophy. After a crisis, basal ganglia injury is also seen as T2 hyperintensity in the putamen and globus pallidus. A critical point is that these magnetic resonance imaging changes can be detected presymptomatically, meaning the imaging changes precede clinical presentation. Key structures to identify include the sylvian fissure, the putamen and caudate nucleus, and the globus pallidus. Case 10. An 8-month-old male is brought to the emergency department following a reported minor fall from a low surface. He has no history of prior trauma. Examination reveals macrocephaly, axial hypotonia, and irritability. Head computed tomography shows a bilateral subdural collection. Child protection services are contacted for suspected non-accidental injury. Which finding in Glutaric Acidemia Type 1 most commonly leads to misdiagnosis as non-accidental injury, also known as abusive head trauma? Option A, retinal hemorrhages. Option B, long bone fractures. Option C, scalp hematoma. Option D, subdural hemorrhage. The correct answer is option D, subdural hemorrhage. In Glutaric Acidemia Type 1, the mechanism involves stretching of bridging veins from expanded cerebrospinal fluid spaces due to frontotemporal hypoplasia. This leads to subdural hematomas that can mimic abusive head trauma. Key distinguishing features include the presence of widened sylvian fissures and basal ganglia changes on imaging, macrocephaly, which is common in about 75% of cases, and elevated metabolic markers, including glutaric acid and 3-hydroxyglutaric acid in urine. In true abusive head trauma, there are no characteristic metabolic brain abnormalities and metabolic screening is normal. Always perform urine organic acids and plasma acylcarnitines in any child with subdural hematoma and macrocephaly before attributing the injury to abuse. Case 11. A 14-month-old boy with newly confirmed Glutaric Acidemia Type 1 via elevated gluteral carnitine on newborn screen confirmed by urine organic acids, is being established on dietary therapy. His metabolic dietitian explains that the diet must restrict specific amino acids that are precursors to the neurotoxic metabolites accumulating in his brain. Which amino acids must be primarily restricted in his diet? Option A, lysine and tryptophan. Option B, valine and isoleucine. Option C, phenylalanine. Option D, methionine. The correct answer is option A, lysine and tryptophan. These are the two amino acids whose catabolism is blocked in glutaric acidemia type 1 due to gluteral coenzyme dehydrogenase deficiency. The dietary approach involves restricting lysine and tryptophan intake while supplementing with a lysine-free amino acid formula to ensure adequate total protein intake. Natural protein is limited to 0.8 to 1.0 grams per kilogram per day. The lysine-free formula provides additional protein targeting 1.5 to 2.0 grams per kilogram per day total. During acute illness, an emergency protocol is activated. Early dietary intervention before the first encephalopathic crisis preserves striatal function, and newborn screening is the key to achieving this. Case 12. A 7-month-old boy with glutaric acidemia type 1, identified through newborn screening, is being started on treatment. His plasma-free carnitine level is low at 6 micromoles per liter, where normal is 30 to 50 micromoles per liter. His metabolic team plans to initiate L-carnitine supplementation. Why is L-carnitine supplementation essential in glutaric acidemia type 1 management? Option A, to increase appetite. Option B, to prevent seizures. Option C, to promote excretion of toxic gluteral coenzyme A metabolites. Option D, to improve muscle tone. The correct answer is option C. L-carnitine conjugates excess gluteral coenzyme to form gluteral carnitine, which is then excreted in the urine. This reduces the neurotoxic load. The process works in 3 steps. First, due to gluteral coenzyme A dehydrogenase deficiency, gluteral coenzyme A accumulates in mitochondria. Second, carnitine conjugation converts excess gluteral coenzyme A plus L-carnitine into gluteral carnitine. Third, gluteral carnitine is excreted in urine, reducing the neurotoxic load. An additional benefit is prevention of secondary carnitine deficiency by replenishing the free carnitine pool. The dose for infants up to 3 years is 100 milligrams per kilogram per day. During acute crisis, the dose should be doubled or switched to intravenous administration. Target plasma-free carnitine is 30 to 50 micromoles per liter. Case 13. A 14-month-old boy with known glutaric acidemia type 1, diagnosed via newborn screening, presents to the emergency department with sudden-onset lethargy, decreased responsiveness, and truncal hypotonia following 2 days of febrile gastroenteritis. He is unable to tolerate oral feeds. Blood glucose is 3.1 millimoles per liter. His parents report he was neurologically intact prior to this illness. What is the first-line inpatient treatment for this encephalopathic crisis? Option A, high-dose antibiotics. Option B, steroids. Option C, mannitol. Option D, high-energy intravenous glucose. The correct answer is option D, high-energy intravenous glucose. The goal is to prevent catabolism during acute illness. For infants, administer 12 to 15 grams per kilogram per day of intravenous glucose. For children aged 1 to 6 years, use 10 to 12 grams per kilogram per day, typically as 10% dextrose solution. Natural protein should be omitted completely for 24 to 48 hours during severe illness. L-carnitine dose should be doubled, and if oral route is not tolerated, switch to intravenous administration. If blood glucose exceeds 150 to 180 milligrams per deciliter, add insulin infusion carefully. Monitor and reassess every 2 hours, including neurological status, glucose, carnitine levels, and oral tolerance. Remember, catabolism is the enemy, and every hour of delay increases striatal injury risk. Case 14. A 4-month-old infant is identified through newborn screening with elevated gluteral carnitine. Confirmatory testing confirms glutaric acidemia type 1. Parents ask about long-term prognosis if treatment is started immediately and maintained consistently. What percentage of pre-symptomatic patients with glutaric acidemia type 1 remain largely asymptomatic with consistent treatment. Option A, 10 to 20%. Option B, 80 to 90%. Option C, 40 to 50%. Option D, 5 to 10%. The correct answer is option B, 80 to 90%. When diagnosed via newborn screening and treated pre-symptomatically, 80 to 90% of patients remain largely asymptomatic with normal striatal development, normal motor milestones, reduced encephalopathic crises, and preserved cognitive function. In contrast, when diagnosed after symptom onset, 80 to 90% develop permanent neurological disability, including bilateral striatal injury, severe movement disorders, recurrent encephalopathic crises, and dystonia with motor regression. The peak vulnerability window is between 3 and 36 months of age. Newborn screening is the single most impactful intervention in Glutaric Acidemia Type 1. It transforms a devastating disease into a manageable condition. Lifelong dietary and carnitine adherence remains essential. Case 15. A 28-year-old woman with known Glutaric Acidemia Type 1, diagnosed via newborn screening and managed since infancy on a low-lysine diet and L-carnitine, presents to her metabolic team at 6 weeks gestation with her first pregnancy. She is currently asymptomatic with stable biochemical markers. Her team begins planning dietary adjustments for the duration of her pregnancy. How should natural protein intake be adjusted during her pregnancy? Option A, gradual incremental increase in natural protein intake throughout each trimester. Option B, strict fasting protocols with complete caloric restriction. Option C, complete removal of all natural protein from the diet immediately. Option D, no dietary changes are needed during pregnancy. The correct answer is option A. During pregnancy in a woman with Glutaric Acidemia Type 1, natural protein intake should be gradually increased each trimester to meet the growing metabolic demands. In the first trimester, increase natural protein by 10 grams per day with L-carnitine at 3,000 milligrams per day. In the second trimester, increase further by 20 grams per day with L-carnitine maintained at 3,000 milligrams per day. In the third trimester, add an additional 30 grams per day and increase L-carnitine to 4,000 milligrams per day. The peripartum period is critical, requiring intravenous glucose infusion to prevent catabolism, intravenous L-carnitine at 3,000 milligrams per day, temporary protein restriction, and close metabolic monitoring. Before we wrap up, I want to tell you about our community on Patreon called Pediatric Case Review. This community contains all our videos arranged by body system, so you can access all videos in one organized place. All presentations used in the videos are also available as downloadable images, so you can read and practice all questions offline at your convenience. We also have a dedicated learning community where you can connect with peers and experts. For details on how to subscribe, comment below in this post, and we will message you directly. Let us now summarize the key takeaways from today's lecture. First, early diagnosis is everything. Newborn screening via gluteral carnitine on dried blood spot catches Glutaric Acidemia Type 1 before irreversible striatal injury occurs. Second, know the magnetic resonance imaging hallmarks. The batwing sign with widened sylvian fissures plus bilateral striatal signal changes should make you think Glutaric Acidemia Type 1 until proven otherwise. Third, act fast in acute crisis. High-dose intravenous glucose plus L-carnitine during illness prevents irreversible striatal injury. Fourth, multidisciplinary care is essential, involving metabolic physician, dietitian, neurologist, and pediatrician working together for lifelong coordination. Thank you for joining this Pediatric Case Review lecture on Glutaric Acidemia Type 1. I hope you found this case-based review helpful for your clinical practice. Please remember that these lectures are for educational purposes only and do not constitute medical advice. Always consult current guidelines and specialists for clinical decisions. If you have any questions, please comment below, and we read every one. Follow Pediatric Case Review for more case-based clinical lectures. See you in the next one.